Good morning, my name is Dr. Sarah Richardson and I'm presenting a systematic review of all-cause presentations to emergency facilities in low-income and low and middle-income countries in sub-Saharan Africa. Emergency conditions constitute a large proportion of the total global burden of disease and annual global deaths. All 10 leading causes of death in low-middle-income countries are conditions which are amenable to emergency care, such as respiratory infection, diarrhoea, road traffic injury and ischemic heart disease. However, much of the emergency care research that's performed in sub-Saharan African regions focuses on a single disease process or particular causations, such as specifically trauma, obstetric or paediatric cohorts of patients. Whilst this gives us helpful information regarding these specific patient types, the data contributes a skewed impression for the overall all-cause emergency care disease burden. Despite calls from international entities such as the WHO for increased availability of quality data to guide the design and adaptation of emergency care systems in low-resource contexts, little research has been done to understand the frequency of all-cause presentations, the burden of emergency conditions, their acuity and management. The overall lack of comprehensive information concerning emergency care delivery has stalled attempts to improve emergency care systems in low-middle-income countries to date. There is a recognised critical need for research documenting the role of emergency care delivery in reducing the global burden of disease and the associated mortality. So to gain a full understanding of the current available information regarding all-cause presentations, we performed a systematic review of emergency care in low and low-middle-income countries in sub-Saharan Africa. We used the databases PubMed, Ovid, Embase and Global Health. Results were limited to those in English published on or after the year 2000. And due to the very limited numbers of applicable records and the many synonyms within the terminology of emergency medicine, we used multiple search strategies across the databases, including a manual Google Scholar search, and reviewed all applicable paper references. Results were deduplicated and full text articles were screened according to inclusion and exclusion criteria. We included retrospective, prospective and cross-sectional studies, which included all-cause emergency presentation data in countries that were listed on the date of the search by the World Bank as low-income or low-middle-income countries in the sub-Saharan African region. We excluded data focusing specifically on subsets of patients, conditions only or outcomes of patients, and also excluded data that was focused purely on the pre-hospital or community setting. Studies that described only gender or age data with no other descriptors reported were excluded, and data from upper middle income countries, specifically South Africa, Botswana and Namibia, were excluded. A total of 19,227 articles were screened at title level, with 43 articles being eligible for full text screening. After exclusion criteria were applied to the full text screening process, a total of 21 articles fulfilled the full inclusion criteria. In terms of data quality, there's no clearly established evidence base outlining what the key variables are for emergency care surveillance in low-income contexts out with specific conditions such as trauma and trauma registries. However, there is a recently published paper that has suggested a minimum core data set that can be applied to low-resource emergency care to allow for fundamental comparisons between data sets across departments and countries. So we therefore adopted this minimum core data set for the systematic review using 6 key requirements for measurements of quality. The results of the 21 papers that we analysed were that they represented 10 countries across the sub-Saharan African region. The results were dominated by data from East Africa alongside Nigeria. There was no representation from Central Africa, and a total of 31 eligible countries did not have data that was represented in the systematic review. Of the 21 studies, 18 were from a single facility, with only 3 including data from multiple sites. The majority of the sites were tertiary referral centres or facilities that were teaching hospitals or in urban settings. There was a wide variety of sample sizes across the study cohort, and a variety of study methodology was used, most commonly being retrospective patient record reviews. Only 4 out of the 21 studies reported measures to ensure data quality or any kind of method to reduce methodological bias. The quality assessed that only 1 out of the 21 studies complied with the minimum core data set that was suggested. In terms of results, age distribution was variably reported with a lack of standardization of age categories. Cut-offs for the adult categories were variable, with some studies considering 13 years old as adult, others using 15, 16, 18, and in one case 19 years as the cut-off. The over 65 population category was significant in the proportion of presentations across the studies when the age demographic of these countries is considered, with usually less than 5 to 10% of the population being over the age of 65. The proportion of paediatric presentations was variable across the papers, with one paper excluding paediatric presentations altogether due to methodology. In terms of acuity, only 3 out of 21 papers mentioned triage category or severity of patients, 2 of which were from Kenya. And with the 2 papers from Kenya, there was a significant difference between the percentage of patients that were fulfilling the highest triage category. The presenting complaint or the reason for attendance was reported only in 6 out of the 21 papers. Respiratory symptoms and gastrointestinal or digestive symptoms, including diarrhea and vomiting, featured in the top 5 presenting complaints of all 6 papers that reported them. Fever or chills were reported in the top 5 presenting complaints in 4 out of the 6 papers. And interestingly, only 2 of the 6 papers that reported presenting complaints noted trauma or road traffic accident to be in their top 5 reasons for attending. All but 2 studies reported a breakdown of conditions that were seen in the emergency facilities into some form of categorization system. But there's no clearly defined or accepted methodology for reporting this. Some papers adapted global burden of disease, using communicable versus non-communicable diseases and injuries, and others used a more traditional breakdown such as medical and surgical patients. A total of 15 studies out of the 21 noted a predominance of medical presentations, with trauma representing between 5 and almost 48% of the conditions seen across the papers. 16 of the studies provided some form of outcome data, with discharge, admission and mortality rates varying significantly. The highest admission rates were reported at 67.2% and the lowest at less than 1%. 2 facilities reported mortality rates at 9 and 10%, with another study reporting rates at well under 1%. This may reflect the level of facility that was being studied, as the highest mortality rates in the papers were from papers that were studying Nigerian national referral facilities. 13 out of the 21 papers reported patient diagnoses, with malaria being the most commonly listed top diagnoses in the emergency department and frequently featuring in the top 5 diagnoses of the other papers. Traumatic injury, respiratory infection or respiratory conditions and gastrointestinal disease were heavily featured in the top 5 diagnoses across all of the papers. Interestingly, one paper from Madagascar listed only traumatic injuries within their top 5 diagnoses, and one paper from Tanzania listed mental illness as the most common diagnoses presenting to their department. So this review demonstrates that despite considerable progress being made in recognising the need for an evidence-based integrated emergency care system across all global regions, critical health system information for emergency care delivery remains lacking across the sub-Saharan African region. This review lacked any data from 31 countries in the sub-Saharan African region, and where data was published, the quality was poor and limited measures were taken to reduce bias and ensure quality. The lack of defined data points for collection in the emergency setting made comparisons across nations, regions and the continent extremely challenging. And where data was available, the attendances were in line with that anticipated from a complex emergency care setting with a wide age range and comprehensive mix of patient diagnoses that require systems to be adequately resourced to manage the full spectrum of emergency conditions. So there's really a need for an urgent critical investment in this context to produce quality data regarding current emergency care utilisation for the policymakers to appropriately allocate resources for the system to meet the needs of the population. And to fulfil this and optimise quality both in analysis and reporting, there has to be a unified guidance for the creation of emergency care surveillance systems throughout the region. This review essentially calls policymakers and investors in resource research in low resource settings to adopt and implement robust, structured and contextualised systems of reporting to allow information sharing, system planning and development of emergency care across the region. Thank you.